Assalamu alaikum class. Today the topic of discussion is susceptible host and time zones in infectious disease epidemiology. This is the last lecture of infectious disease epidemiology. Since we have started the infectious disease epidemiology, we were discussing the chain of infection. And in our previous lectures, we have discussed that the chain of infection has three important components. The one and the foremost important is the source and the reservoir where the infectious agent is present. This infectious agent gets transferred from the source or the reservoir of infection to the susceptible host by a suitable mode of transmission. This is the simplest model of maintaining the chain of infection. We have already discussed the difference between the source and the reservoir, that just mere the presence of infectious agent is in any living thing or non-living thing is considered as source, and if the infectious agent is present and is multiplying in its host, then it is known as reservoir of infection. We have already discussed that there are three different types of reservoirs: the human reservoirs, animal reservoirs, and non-living reservoirs. In human reservoirs, we have discussed that there may be cases or there may be carriers, and then we have further subclassified cases into different categories, and we have further subclassified the carriers into different categories. There are different modes of transmission of disease. In our last lecture, we have discussed that there are direct mode of transmission and indirect mode of transmission. The direct mode of transmission include the direct contact. It includes the contact with soil. It includes the droplet infection, inoculation into skin or mucosa. It also includes the vertical transmission. Another mode of transmission that we have discussed in our last lecture is the indirect mode of transmission, which includes number one, vehicle-borne transmission, which is basically the medium of transferring the infectious agent through food or through fluid or through blood, or it can be any fruit, milk or milk products or vegetables which can transmit the infection. Then there are vector-borne transmission. In vector-borne transmission, the involvement of arthropods, vertebrates, and other invertebrate animals can be included. Then we further subdivided the vector-borne transmission into mechanical transmission and biological transmission. The biological transmission was further divided into propagative transmission, cyclopropagative transmission, cyclodevelopmental transmission, transvariant, and transstadial transmission. And now the other indirect transmissions included the airborne transmission through droplet nuclei and dust, fomite-borne transmission, and transmission of infection through the unclean hands and fingers. So now we are going to discuss the last component of the chain of infection, which is the susceptible host. Whenever we talk about the susceptible host, we say that the susceptible hosts are those hosts which can harbor the infectious agent and then they produce signs and symptoms. Sometimes all those people who are being exposed and do not get the disease, they are known as not susceptible or immunized hosts. The immunization occurs in case of provision of the vaccine against specific diseases, or if the community has suffered from active cases or the community has suffered from the subclinical cases. These are three important conditions which prevent the transmission of infection from the source or reservoir through a mode of transmission, even if the environmental conditions are suitable. How the susceptible host gets transferred into the immunized host is through three mediums. Number one, the vaccination against a specific disease has been done. Number two, the community has suffered from the clinical infection and has developed immunity. And number three is the community has suffered from subclinical infection. The sign and symptoms were not evident, but the infection was sufficient enough to produce the immunity in the host. So the most important thing is that a susceptible host is the host which does not have an immunity, and now he can harbor the infectious agent and can produce signs and symptoms. The other host is known as the immunized host, and if the source or the reservoir of infection transmit the infectious agent through the mode of transmission, the normal route of transmission to the immunized host, the disease does not get transmitted. So moving further, when we talk about the susceptible host, it is important to know that the portal of entry is important for the development of the disease in the susceptible host. Sometimes the portal of entry can be a single portal of entry. For example, in case of measles, respiratory route, the virus enters through the respiratory route. For example, in case of polio, the virus enters through the orophycal route. For example, in case of rabies, the virus enters through the dog bite route. But sometimes there are certain diseases in which the portal of entry can be multiple. For example, in case of transmission of hepatitis B, the portal of entry can be through the intravenous route, through the blood transfusion, or it can be through sexual contact. It can be done through the needle contact, which is contaminated with blood. So there are different options. In some diseases, the portal of entry is one, and in some diseases, there are multiple portals of entry for the entry of the infectious agent into the susceptible host. After getting entry, the infectious agent selects a site which is suitable for its multiplication and manipulation of the sign and symptoms. For example, whenever the hepatitis B virus enters, it lodges itself in the liver and produces sign and symptoms. For example, whenever the polio virus will enter, it will multiply in the pious patches of small intestine, and then it will invade in the bloodstream to produce the sign and symptoms. For example, in case of tetanus, the portal of entry is basically the breach in the skin, and through skin, the tetanus spores enter and they produce the exotoxin, and the exotoxin then gets attached to the neuromuscular junctions, and seizures occurs through which are tonic clonic in nature. So basically it is important that the site of election is important for the infectious agent, because the infectious agent will attach there, it will get the suitable environment, and then it will multiply and it will produce sign and symptoms. Then these susceptible hosts are converted into cases when they produce the sign and symptom. Again, to maintain the chain of infection, the cases has to excrete the infectious agent through the portal of exit so it can infect other susceptible hosts. Sometimes the portal of exit is same as that of the portal of entry. For example, the measles virus enters into the susceptible host through the respiratory route. It gets multiplied, it produces the signs and symptoms of measles, active measles disease, and then it gets excreted through the same route, which is the respiratory route, and through the droplet infection and the droplet nuclei. But sometimes the portal of exit is not the same, and the infectious agent stays in the body. Sometimes it causes death, and sometimes it does not have any portal of exit which can be usually seen. For example, in case of rabies, rabies is a fatal disease. The Lyssa virus enters into the body of the susceptible host through dog bite, and then it produces the sign and symptoms. The rabies is such a fatal disease that the patient dies within 2 to 3 days. There is no portal of exit for the Lyssa virus through the clinical cases to infect the other susceptible host. So it becomes a dead end infection. There are certain diseases in which there is no portal of exit. For example, tetanus. In case of tetanus, there is no portal of exit. In case of bubonic plague, there is no portal of exit. In case of trichinosis, there is no portal of exit. So to complete the chain of infection and to avoid the dead end infection, both portal of entry and portal of exit are important when we are talking about the susceptible host. And the most important thing is the selection of the site where the infectious agent will multiply itself. Moving further, today we will also be discussing the important time zones which are important for the infectious disease epidemiology. These time zones include incubation period, median incubation period, latent period, serial interval, generation time, and communicable period. In respect to the communicable period, the infectious disease epidemiologists are always concerned to calculate two rates, which are known as attack rates and the secondary attack rates. So we will be discussing them one by one. These are very important from the examination point of view. So going towards the incubation period, how do we define incubation period? It is the time interval between the invasion of an infectious agent and appearance of the first sign and symptom of the disease. So whenever the infectious agent enters into the body, it stays there, it multiplies there, and then after a certain time period, when it attains a threshold value to produce the clinical sign and symptoms, then it produces the clinical sign and symptoms. So the time interval between invasion of an infectious agent till the appearance of the first sign and symptom of the disease is defined as an incubation period. So let me give you an example. For example, there is an infectious disease and the incubation period is shown in number of days on the x-axis and the number of cases appearing on the y-axis. So let's consider that the invasion of the infectious agent occurs here, and this is the time period where no clinical sign and symptom appeared in any of the case. This is the primary case, and in the primary case the appearance of the first sign and symptom is shown by this. So the time period between the invasion of the infectious agent till the entry till the appearance of the first sign and symptom in the primary case is known as the incubation period. Again, just to give an emphasis that this is the infectious agent when it gets entered into the body. There is a certain time period in which there is no sign and symptom because the invasion of the infectious agent does not reach the threshold value to produce the sign and symptoms. The infectious agent gets multiplied in the body of the susceptible host. It produces a threshold value and then it produces the sign and symptoms of the disease. So the time period between the invasion of the infectious agent till the appearance of the first sign and symptom of the disease is known as incubation period. The incubation period is important for us to trace the source of infection and the contacts, because if we have a shorter incubation period, we can trace that what was the source of infection and what are the different contacts which are at high risk of developing the disease. In case if the disease has a shorter incubation period, it is easy for the public health consultants to trace the source of infection and contact. But if the period is longer, it becomes difficult for public health consultant to trace the source of infection and contact. According to the period of incubation period, we can divide the diseases into different components. For example, there are certain diseases in which the incubation period extends up to only few hours to 1 to 2 days. For example, the staphylococcal food poisoning, the mean incubation period in case of staphylococcal food poisoning is only 6 hours. For example, the influenza, in case of influenza, the incubation period is only 2 to 3 days. So in diseases where the incubation period is shorter, we can easily trace the source of infection and the contact who are at risk of developing the disease. But there are certain diseases who have median incubation period. The median incubation period can extend up to few days. and then from few days up to few weeks or 2 to 3 weeks. The example can be the presentation of polio, it can be diphtheria, it can be pertussis, it can be measles. But there are certain diseases which has a longer incubation period which extend more than few weeks, and they can extend up to few years. For example, in case of presentation of hepatitis B and hepatitis C, and there are few other examples, for example, the leprosy, where the time period for the development of the sign and symptoms can extend more than few weeks, and they can extend up to certain years. So this is the example of diseases having different incubation periods, and those diseases which have the shorter incubation period. In those cases, it is easy for the epidemiologist to trace the source of infection and contact. It is important to know about the incubation period because it tells us about the period of surveillance. I will give you an example. For example, we all know that the incubation period for the COVID-19 is about 10 to 14 days. And because whenever the infectious agent enters into the body, it produces signs and symptoms within 10 to 14 days. So the period of surveillance, which is basically fixed for the international travelers and those people who are being exposed, and the period of quarantine, and the period for which the exposed people are basically monitored, is 10 to 14 days. So incubation period tell us tell the public health consultants about the period of surveillance. It tells us that when to do immunization in case of exposure. For example, in case of passive vaccines which are given after the exposure, which include the specific immunoglobulins and anti-sera preparation, they are given within the incubation period, and diseases tell us that within 24 to 48 hours of exposure of the infectious agent, we need to immunize with that specific particular antibodies and anti-sera to prevent the disease. Another important thing is that incubation period tells us about the type of epidemic which has occurred. And we all know that epidemic means the occurrence of cases more than the expected number. So there are two types of epidemics, the point source epidemic and the propagated epidemic. The point source epidemic has a sharp rise, and then it reaches up to the maximum, and then there is a sharp fall. So the incubation period is only one for the point source epidemic. But in case of propagated epidemic, we have propagated waves. And the recent example of propagated epidemic is COVID-19. For example, the presentation of staphylococcal food poisoning will be that once the patients have eaten a specific food, there will be a sudden rise of the cases with the presentation of signs and symptoms, and after treatment there will be a certain sharp decline that the symptoms will settle down and the patient will be recovered. That shows the point source epidemic with a single incubation period. But in case of propagated epidemic, I will give you an example of the COVID-19 pandemic, in which we are facing the third epidemic wave. We all know that the COVID-19 has shown a rise in the patients and then fall. After a certain time period, there was again rise, and then there was a fall in the number of patients. And this is the third wave we are facing, in which there is again a certain rise of the cases. So in case of propagated epidemic, there are multiple incubation periods are observed because of the multiple exposures which occur in different communities, and different communities present with a large number of cases in the form of waves. Another important significance of incubation period is that it tells us about the prognosis of disease. Although it is not a very good marker to predict the prognosis, but certain fatal diseases have a very short incubation period. For example, rabies and tetanus have a shorter incubation period, and it is predicted that as shorter the incubation period will be, the prognosis will be worse in cases of rabies and in cases of tetanus. So the epidemiological significance of incubation period is very high, and we as epidemiologists, we as public health consultants are always concerned about the incubation period in which the number of cases will appear with the appearance of the sign and symptoms and after the invasion of the infectious agent. Another phenomena of time zone is the median incubation period. The median incubation period is the time interval required for 50% of the cases to occur after exposure. For example, if in a community an exposure of an infectious agent occurs, the time interval between the entry of the infectious agent till 50% of the cases parents of the cases will be labeled as median incubation period. Let me explain it to you. For example, this is the time period of the introduction of the infectious agent into the community, and this is the time period in which the first sign and symptom of first case appeared, which is known as the minimum incubation period. Fine. In this case, the sign and symptoms appeared only after 4 days of the exposure. This is known as the minimum incubation period. In some cases, the disease has occurred after the exposure of almost 10 to 12 days of the disease. This is the time when the invasion of the infectious agent took place, and this is the time period when the sign and symptoms of the last case appeared. So this shows the maximum incubation period. And whenever we talk about the number of 50% of the cases which have appeared in the community after the invasion of the infectious agent, it will be labeled as average incubation period, or the other name given to it is the median incubation period. So, median incubation period will be defined as the time interval between the invasion of the infectious agent till 50% of the cases get emerged in the community. This will show the median incubation period of that disease. Moving further, I will give you an example of COVID-19 again. And we all know that if we presume that the infectious agent has entered into the body here, some of the people will develop disease within 24 hours. Some of them will develop at an interval of 2 days, some will develop at the interval of 4 days, some will develop at the interval of 6 days, 8 days, and 10 days. But when we look at the normal pattern of the presentation of the COVID-19 clinical features, we observe that maximum number of cases appear after the invasion of the infectious agent within 5 to 6 days of the infection. So the 50 appearance of the 50% of the cases in the community after the invasion will be labeled as median incubation period, and this median incubation period in case of COVID-19 is of 5.1 days. The minimum incubation period can be 0 days, the maximum incubation period can be 10 days, but in the middle, when the 50% of the cases will be appeared and the maximum number of cases have appeared after the invasion, will be labeled as the median incubation period, which is about 5.1 days in cases of COVID-19. Moving further, let's discuss another important topic which is known as latent period. The latent period is the time period in which, after invasion of the infectious agent, the infectious agent lies in the body of the susceptible host without any sign and symptom and without infectivity. It is not present in a sufficient amount to produce the sign and symptoms, and it is not present in a sufficient amount to infect the others. So it is present in the latent phase. So the latent period is the time period in which the infectious agent has no ability to produce the sign and symptom, and it does not have the ability to infect the other susceptible host, is known as latent period in case of infectious diseases. But this term is also applied out of the context of infectious disease epidemiology, and this term is also used in the provision of non-communicable diseases. In case of non-communicable diseases, the latent period is defined as the time period from disease initiation to disease detection. For example, we all know that in case of non-communicable diseases, which are basically hypertension, obesity, which can be coronary heart disease, the as soon as the baby is born, the process of disease starts. As soon as the baby starts taking food from the external sources, the process of atherosclerosis starts. So that is the time period when the disease initiation takes place. But after many years of the exposure, the atherosclerosis is strong enough to block the coronary artery and produce signs and symptoms. So that is the time period when the disease can be detected on the basis of signs and symptoms, and it can be detected on the basis of other diagnostic criteria. So the latent period is the time period from disease initiation to disease detection in case of chronic non-communicable diseases, and in case of infectious diseases, it is defined as the time period from the invasion of the infectious agent till the time period when it is not capable of producing any sign and symptoms, and it is not capable of infecting the other secondary cases. Moving further, another concept is of serial interval. The serial interval is defined as a time period between the onset of a primary case and a secondary case. We all know that a primary case is the first case which appears in the community, and secondary case is the case which originates after getting infected from the primary case. So the time period between the onset of the infection and the clinical signs and symptoms in the primary case to the secondary case. Let's assume this is the primary case. The infectious agent has entered into the body. There was a certain time period of latent period when neither the infectivity was there nor the period of sign and symptom. Then the latent period is just not the overlap of the incubation period, because the incubation period extends from the invasion of the infectious agent till the appearance of the first sign and symptom. So from the appearance of the first sign and symptom of the primary case, and this is the secondary case in which the sign and symptoms have appeared here. When the primary case becomes infective, the infection will occur to the secondary case. So the time period between the onset of sign and symptoms in the primary case to the onset of sign and symptoms in the secondary case is known as the serial interval. Let's not confuse the primary case with the index case, as the primary case is the first case which appears in the community with specific signs and symptoms, and the index case is that first case which comes to the healthcare service provider to seek the healthcare service provision. So there's a difference between the primary case and the index case. The serial interval measures the time period between the appearance of signs and symptoms of the primary case and the secondary case, not the index case. The next concept is the generation time. The generation time is the time interval between the receipt of the infection by the host till it reaches the maximum infectivity is defined as the generation time. Let me explain it to you through this. As we have seen, this is the first patient. This is the latent period. This is the incubation period. This is the clinical disease. And in this infectious period, this is the period of infectivity, when now the patient can transmit the infection to the other people. So during this period of infectivity, the infection gets transmitted to the second patient, And then this second patient develops again the latent period and the incubation period and the development of signs and symptoms, and then develops the infection, and now this particular person goes into the phase of the infectious period. So during this infectious period, when the maximum infectivity is attained from the time of the exposure till it reaches to the maximum infectious stage, is known as generation time. So let me explain it again. The generation time, if we assume that this peak shows the infectiousness and this shows the invasion of the infectious agent, the time period from the invasion of the infectious agent till no sign and symptom is produced and neither the disease is communicable, this is known as latent period. The time period between the invasion of the infectious agent till the development of the sign and symptoms in the primary case is known as the incubation period. The time period between the invasion of the infectious agent till it reaches the maximum infectivity, it reaches the peak of infection, is actually labeled as the generation time. And the time period between the appearance of the first case and the appearance of the second case with the appearance of the sign and symptoms is termed as the serial interval. Moving further, we will be discussing another important concept which is known as communicable period. This is the time period in which the disease can be communicated to the other susceptible host. This host can be a human being, it can be an animal, it can be a vector, it can be a bird. So the disease transmission, the time period during which an infectious disease can be transmitted or it can be communicated from one person to another person, from one person to an animal, from animal to human beings, or from animals to arthropods, or from humans to arthropods, is known as communicable period. So basically the communicable period reflects the period of communicability of the infectious disease. Moving further, whenever we want to discuss the communicable period, we are concerned with two types of rates. Number one is attack rate, and number two is secondary attack rate. The attack rate actually defines the number of cases those who are showing the signs and symptoms divided by the number of individuals who are exposed to a specific organism. For example, in case of COVID-19, this is the index case who is suffering from the source of who is suffering from the clinical sign and symptoms and is capable of transmitting the infection, goes in a community or goes in a gathering where a large number of people are there. So the disease is transmitted to all the yellow people who come into contact with this red index case, and the people who have not developed the disease are the unaffected people, which are labeled with the yellow consideration. So if we want to calculate the attack rate, we will calculate the total number of cases which have occurred in a community after exposure with the index case divided by all the number who were exposed by this index case will tell us about the attack rate. In case of COVID-19, the attack rate is almost about 87%. But my question to you is that why these people have not got the disease? These may be the people who may be immunized against the COVID-19 through COVID vaccine, or these may be the people who have developed immunity after primary infection. Maybe they were exposed a few days earlier and they have passed through the stage of clinical signs and symptoms and now they have developed immunity. Or maybe they have suffered from the subclinical infection and have developed the immunity. That's why they are not being infected. So if we take them out from this total number of people who were exposed and we assume that these were immunized, then the attack rate will be 100%. Fine. So in case of the exposed or immunized status, we want to calculate not the attack rate, but we want to calculate the secondary attack rate. So this person now has entered into the community, and only these people were susceptible of getting the infection, and these people were immunized. So if I'm going to calculate the attack rate, in this case, it will be 100% if I will take the immunized cases and the people who are who have actually developed the disease. It will be 100%. But while calculating the attack rate, the numerator is taken into account as the total number of cases who have developed the disease and all those who have been exposed irrespective of their immunized status. Let me explain here again that whenever we want to calculate the attack rate, we calculate it by the total number of people who have developed the sign and symptoms and who have developed the disease out of all who were exposed irrespective of their immune state. But if we take into the consideration the immune status, we calculate the secondary attack rate. The secondary attack rate says the number of exposed people who develop the disease within the range of the incubation period after exposure from the primary case divided by the total number of persons exposed to the primary case who were susceptible to get the infection. So it is important to note that secondary attack rate is calculated only from the susceptible population. We take out the immune population from the denominator. We subtract the immunized population from the susceptible population and we calculate the secondary attack rate for them. So now your first assignment is that in an outbreak of gastroenteritis among attendees of a corporate picnic, 99 persons ate potato salad, 30 of whom developed gastroenteritis. Calculate the risk of illness among persons who ate potato salad. So, in a nutshell, we are asking you to calculate the attack rate in those who have eaten the potato salad. Your assignment 2 is that consider an outbreak of shigellosis in which 18 persons in 18 different households became ill. And if the population of the community was 1000, then calculate the attack rate for this population. And the second component says that one incubation period later, 17 persons in the same household as these primary cases developed shigellosis. If the 18 households included 86 persons, now calculate the secondary attack rate. So now you have to be very careful while calculating the attack rate and the secondary attack rate. I must re-emphasize that while calculating the attack rate, the formula becomes the total number of people who get the disease divided by the total number of people who were exposed to the disease. While calculating the secondary attack rate, you calculate it as the number of people who develop signs and symptoms after exposure to the primary case divided by the total number of susceptible population. Susceptible population is the key. While discussing the secondary attack rate, you must know that it is important that the diseases which have a shorter incubation period, uh, it is important to note that the secondary attack rate is usually um, difficult to calculate because with the shortest incubation period, the signs and symptoms develop and you cannot differentiate between a primary case and the secondary case. Fine, it is difficult to identify the susceptible population in a community. And sometimes the subclinical cases do not appear in the community because of the lack of presence of signs and symptoms, but they get immunized. So in a nutshell, it becomes difficult to find out that what is the number of total cases which were subclinical but they have developed the immunity. But there are certain diseases we have high secondary attack rate. For example, we have COVID-19, in which the secondary attack rate is very high. In case of measles, in case of chickenpox, the secondary attack rates are very high. So with this, I will end my lecture. This finishes the infectious disease epidemiology, and soon we'll be starting with the epidemiology of respiratory diseases, and we will be discussing the first chunk of the communicable diseases, which are actually transmitted through the respiratory route. With this, we have finished the infectious disease epidemiology. If you have any questions, you can ask me. I'm available on Facebook. I'm available through WhatsApp. I'm available for your calls, and I will appreciate if you have any question. I'm available to answer it. Thank you so much.